Case report title: Survival following a type A aortic dissection amidst multiple postoperative complications. Presenting Gilbert Flores, PGY3 from the University of Texas, Rio Grande Valley, at Internal Medicine at Valley Baptist Medical Center, Harlingen, Texas. Background: aortic dissection, a rare yet critical condition, manifests as severe chest pain radiating to the back and hemodynamic instability. Familial ties, especially among immediate family members, contribute to around 20% of thoracic aortic aneurysm or dissection cases, following an autosomal dominant pattern. Potential complications include pericardial rupture, aortic valve involvement, post-surgical complications including bleeding, thrombosis, and acute renal failure can arise. Cardiac surgery may lead to atrial flutter, either postoperative or delayed. Presenting case: the patient is a 33-year-old male patient with no past medical history, however known family history of Marfan syndrome on the grandfather's side, who presented with a sudden collapse during sexual intercourse, leading to cardiorespiratory arrest. His spouse initiated cardiopulmonary resuscitation, and DMS performed emergency intubation. The initial chest CT scan revealed a significant pericardial effusion of approximately 4 centimeters and aortic dilatation of 6 centimeters. A follow-up TEE revealed a large ascending aortic aneurysm of approximately 6.5 centimeters with a large dissection flap. The surgical procedure involved replacing the aortic root with a 23mm connect graft and replacing the ascending aorta and hemiarch using a 26mm Dacron graft. The cardiothoracic surgeon evacuated the pericardial effusion and established the femoral artery and vein axis for cardiopulmonary bypass. He encountered substantial bleeding in the thoracic cavity, leaving his chest open for 2 days after the operation. After managing the chest output, he underwent a second intervention to close his chest. Complications included disseminated intravascular coagulation, acute renal failure, and counterclockwise type 1 atrial flutter with rapid ventricular response. Despite attempts with medications such as metoprolol, amiodarone, and cardioversion, the atrial flutter proved refractory and required eventual resolution through ablation. Following the surgery, the patient experienced bilateral lower extremity limb ischemia. An arterial Doppler assessment confirmed a popliteal occlusion of the left lower extremity, prompting an emergency bedside thrombectomy of the affected limb. Additionally, due to compartment syndrome, the patient underwent bilateral fasciotomies. The patient's bilateral lower extremity ischemia necessitated above-knee amputations due to non-viable tissue to the lower extremities. After the amputations, the patient's renal function improved, leading to discontinuation of dialysis after approximately 1 month. The patient, upon significant improvement, was transferred for intense rehabilitation at an advanced facility. Discussion: individuals with familial background of Marfan syndrome face a heightened susceptibility to aortic dissection. Inquiring about the genetic heritage of this condition is crucial. Family members should undergo genetic screening for Marfan syndrome, given that even younger patients may encounter substantial complications following aortic repair surgery. Additionally, there is a potential for the emergence of atrial flutter, bearing in mind the possibility of it being unresponsive to cardioversion, thereby warranting consideration of ablation as a potential intervention.